Hello, everyone. My name is Joey Tapia. I'm an alumni of the Rehabilitation Counseling Program, and I will be with you here today to talk about traumatic brain injuries followed along in your DSM for major or mild neurocognitive disorder due to traumatic brain injury. I'm also going to touch on Parkinson's disease as we go along. So I want to start off with just a little bit about my background. I graduated from the UNT Rehabilitation Counseling Program in 2015. I've worked in state VR services and also in private rehab working with people with traumatic brain injuries. I currently am a first-year doc student in a counseling program here at UNT. And when I saw what you guys were learning, I wanted to jump on the opportunity to talk about traumatic brain injury and what that kind of looks like from a rehab setting. So within the DSM, under the neurocognitive disorders, there are several listed under major or mild neurocognitive disorders, such as Alzheimer's, frontotemporal lobar degeneration, vascular disease, traumatic brain injury, substance medication use, HIV infection, Parkinson's disease, Huntington's disease, and so forth. I wanted to touch on only two just due to time. And based on the areas that I have worked, the populations I have worked specifically with, to provide you guys a little more in-depth knowledge of what it looks like in practice. So for the DSM criteria, to be diagnosed with a traumatic brain injury, there has to be a loss of consciousness, post-traumatic amnesia, disorientation and confusion, and neurological signs such as an onset of a seizure, worsening of a pre-existing seizure disorder, visual field cuts, and hemiparesis. I'm going to dive into all of those in terms of functional limitations in a little bit. So in terms of a traumatic brain injury and what that looks like for someone, it is presentation-wise very different. There are several types of traumatic brain injuries that can occur from an external force. One of them can be a closed head injury or an open head injury. And then even those, based on the magnitude, they look very different in terms of the person's functional abilities. I did want to cover a little bit about in terms of lifespan with a traumatic brain injury. I think I'll start first with youth, a child or adolescent that acquires a brain injury. One of the things to note about this is the symptoms are not always present after a brain injury that results in loss of consciousness, disorientation, and confusion. What you would label as a major or mild traumatic brain injury, the limitations in terms of cognitive or functional abilities might not be evident immediately. Those might take time to develop. One of the things that we see in research and in practice are youth that acquire a traumatic brain injury don't develop serious issues or limitations until their teens, early adult, young adult, around the late teens, 17 to I would say 24, is where you typically see signs of the injuries that they acquired when they were little. Part of that reason is because the brain is still forming and developing into an adult-sized brain around that time. There are regions such as the frontal lobe that's not fully developed yet until early 20s. So areas like that, you won't really see effects immediately. They might present as inability to sustain attention, difficulties with regulating emotion. There's several other functional wise as well. Maybe their strength is not good on one side or with one specific limb. And you typically would see that as they progress in age. So what we do with that is, as a rehab counselor, we step in to provide services in terms of filling the gaps that they might be experiencing in education or in employment or psychologically. One of the things that is prevalent among people with traumatic brain injuries is depression, often related to post-traumatic stress disorder as well as anxiety. some of the functional limitations for children that might experience a traumatic brain injury, where the effects are immediate, are motor impairments, so fine and gross motor skills. They won't be able to pick up pens, they won't be able to grasp something. That's typically seen immediately, as well as physical effects, disruption in their growth, eating disorders, development of diabetes. Um, Sometimes what we, I think, is more prevalent in adults as well as children is feeding disorders. So dysarthria, which is disrupts the ability to swallow. So feeding has to be retrained, has to be practiced with a speech language pathologist. Sensory impairments, vision is a major one, as well as hearing. Oftentimes, what I mentioned earlier in terms of neurological signs, the visual field cuts. What that means is our visual field, um, we it is a when they examine you, it's a circular visual field. Those cuts come in at different parts depending on where the impact was, and just a little anatomy in terms of how everything is connected. Our left hemisphere is connected to things on our right. Our right hemisphere is connected to what's on the left. So this kind of crossing that occurs. So if there's damage on the right side, sometimes, most often, if it was, depending on where in terms of the lobe that was affected, you will have visual cuts or visual acuity difficulties on the left side. And that might be half a field, it might be partial. It varies again with the degree of the brain injury, as well as age. And then communication impairments. This is a big one. I focus a lot on communication when I worked with this population. Um, Expressive and receptive language can be interrupted, meaning I'm speaking to you, you are hearing my voice. You might not be able to understand my voice because what I would perceive to be words are not words that are intelligible. Um, that or receptive, what I'm hearing from you does not make sense. The pathways have been disrupted and I'm not able to interpret what you are saying and provide meaning to it. And those can be referred to as aphasia, receptive or expressive aphasia. Those types of instances, recovery takes a little more time. From a cognitive standpoint, this you're going to see, I think, across the board with any type of brain injury, either mild or major. You're going to find attention, memory, executive functioning skills, speed of processing being impacted. And what this looks like in an adult is someone that might exhibit symptoms of ADHD. I think one of the things we do as clinicians is we take from what we learn in case management and some of our other courses, we take really good notes on background information. So one of those things is understanding past history of brain injury. If they're diagnosed with ADHD or you see signs of ADHD, we want to be careful because that might be stemming from something else. Memory also is impacted, short-term working, long-term memory. Executive functioning. So when we think about frontal lobe function, when a brain has fully developed in terms of regions, around, I would say 24, 25, depending on male or female, those functions are really strong. Our executive functioning skills, our planning, sequencing, processing, all of those things occur up here. Problem solving. When that is impacted or when it is impacted by a brain injury, the extent of that varies, again, depending on where the impact was. If they were a child, they might be experiencing really strong difficulties with that. As an adult, oh God, how many minutes have I done? Hi, I'm Joey Tapia. I am a alumni from the Rehabilitation Counseling Program here at UNT. I graduated in 2015 and have worked in the field in the private state BR system and as well as in private rehab, working with people with traumatic brain injuries and stroke. Hi, Hi everyone, I'm Joey Tapia Fusile. I am a counselor. Hi everybody, my name is Joey Tapia Fusile. I am a counselor. Hi everyone, my name is Joey Tapia Fusile. I am a graduate of the Rehabilitation Counseling Program at University of North Texas. I graduated in 2015 and have worked in the field prior to and after. I worked in the state VR system, working with the deaf and hard of hearing population as a primary disability, and worked in private rehab, working with people who have acquired a brain injury or a traumatic brain injury. So today, the topic I'm going to help present is from the DSM, from your weekly readings, are the major and mild neurocognitive disorders, specifically due to a traumatic brain injury, as well as Parkinson's disease. I wanted to touch on those two because I feel that is an area that I am well versed in and that I was immersed working at Center for Neuroskills, where I worked as a counselor with patients and their families. So I'm going to dive into what the DSM labels as diagnostic criteria. For a traumatic brain injury, there must be a loss of consciousness, post-traumatic amnesia, disorientation, and confusion, or neurological signs. Some of these can be an onset of seizure disorder or a worsening of a pre-existing seizure disorder, visual field cuts, and hemiparesis. Those are a few that they label in there. One of the things to know about traumatic brain injuries is cognitive presentation in terms of abilities varies greatly. There is no specific way to label this person's going to have this type of cognitive ability after this type of brain injury. It all depends on the severity of the brain injury, their age, previous cognitive function, etc. So I want to talk a little bit about some of the functional abilities that go along with traumatic brain injury. We have, in terms of from a rehab standpoint, there are a lot of things that we are going to look at when we work with someone with a traumatic brain injury or a stroke. But specifically, we're going to be talking about traumatic brain injuries. And for these, we look at from the motor impairments, which are considered gross and fine motor, strength, coordination, and speed. So what happens when someone experiences a brain injury? Their fine and gross motor skills, their ability to grasp, pinch, pick up, those are the coordination and all of those sequencing of movements are very easy for us to do without a brain injury. When we add a brain injury, oftentimes you will experience difficulties with that. Recovery for that requires intervention either through occupational therapy or physical therapy. Physical effects, disruption in growth, eating disorders, and development of diabetes. Some of the things that we see happen is after a brain injury, the internal ability to regulate itself becomes difficult. What we often see in the research is sleep apnea being a contributing factor after someone has a brain injury. So the sleep is disrupted. Also, their ability to regulate. So oftentimes people are placed on medication for high blood pressure, given treatment for diabetes because some develop an onset for diabetes. Some people develop an onset of seizure disorder depending on where the brain injury was, how severe it is, and so forth. Feeding disorders are common. What's known as dysphagia, which is difficulty with the motor functionings of swallow. So when you swallow, we swallow and it happens very quickly. Someone with a brain injury, those types of functions, the speed in which it occurs is not fast enough or safe enough. So some asphyxiation can occur and possibly harm for potential pneumonia and other things that can develop if it goes down the wrong way. Sensory impairments, we're looking at vision and hearing. I mentioned earlier, from a vision standpoint, the field cuts. And within our own visual field, after someone has a traumatic brain injury, oftentimes what happens is their visual field is impacted. So they are only able to see maybe half from both eyes. So they're only able to see this side of their visual field. Now, if we take a step back and kind of look at in what that would look like in someone's day-to-day, they would not be able to read left to right. Their scanning ability for driving is impacted. Their ability to read, to write, you will see where they start is not where the starting point is. Or if they work on an assessment, they will start and not touch things that they are not able to visually see. Now, what I have learned through my time working with people with brain injuries is the brain is able to pick up the messages, it just doesn't know that they're there. That would be an inattention type of visual inattention. The stimuli is coming in, but the brain is not recognizing it as an image. Field cuts from what I've experienced, is just the brain is not seeing that at all and not giving any attention to it. So that requires a lot of occupational type therapy to help rehabilitate some of that eye function. Communication impairments, this is a big one that I've experienced working with people with traumatic brain injuries. We often see difficulties with expressive and receptive language. And what that means is, from a receptive standpoint, anything that you are saying to me, I'm not interpreting it as language. It is jarbled up and it's not being filtered the way it would normally. From an expressive standpoint, everything I am saying is not fluid. It does not make sense. Or sometimes it takes a while for those words to come out, and it's a more slower type of communication that occurs. It's harder to find the words and bring them and pull them out through our communication systems. Cognitive impairments, I think when you're reading, you will see from a mild to major traumatic brain injury, you will find there are cognitive impairments on some level, whether that be due to attention, memory, executive functioning, speed of processing. Those are big when it comes to someone in rehabilitation, in recovery from their brain injury. They're often involved in cognitive retraining through a speech-language pathologist. Speed of processing can be worked on in speech-language pathology, or in occupational therapy. You often find a lot of tasks that are very focused on trying to rebuild those skills that were once there. From an academic standpoint, so when we're working with youth, adolescents, if they have had a brain injury, they might experience physical and cognitive fatigue. This is not abnormal. This is associated with the brain injury. If you can think about, what's a good analogy that will help? If you think about the brain being damaged, it is working extra hard to give you everything you need to sustain all your bodily functions and life. When that is impacted by a brain injury, the amount of effort that's being put in is a lot more. So if they're in rehabilitation, receiving occupational, physical, speech therapy, they're constantly going to be forced to give a lot of output of energy. They're going to be working and working and working. They're going to experience physical and cognitive fatigue. So what that looks like is someone that is extremely exhausted and tired and appears to be weak in their abilities to do anything, maybe after a day or a few hours. The recovery process for someone with a brain injury varies greatly depending on how severe it was. And I wanted to talk about the impact on employment when it comes to someone with a traumatic brain injury, and the dynamics to pay attention to as a rehab clinician. We are given such great training on the holistic view of a person. So when we deal with someone with a disability, specifically a brain injury, we have to be mindful of the components that are involved in that. And one of those is employment. We know employment's going to be affected. From my experience, I worked with a lot of, let's label them as breadwinners of the family, the ones that primarily brought in the income to the family, um, as being the ones affected with the traumatic brain injury, whether this be a car crash. Other special populations to consider with traumatic brain injury is the military. Um, we often see a lot of traumatic brain injuries from their years of service. Football, any boxing, any type of employment that sustains a lot of damage, or an accident like a car accident, a fall, at work possibly. So just being mindful of the different considerations for how someone might acquire a traumatic brain injury. So when it comes to employment, what we often see is loss of wages that impacts the family greatly. So we're not only dealing with where the client is at in that moment in their recovery, but we're also dealing with the employment side and the financial stressors that is now placed on the family. And then we have to look at their level of adjustment. So if we're working with someone who has been in acute rehab, which is in the hospital receiving rehabilitative services there, now in a post-acute type setting, which is it can be inpatient, outpatient, which is Center for Neuroskills. It's in a post-acute traumatic brain injury facility, where they receive rehab there every day, and they might stay there in a residential treatment, or they might return home as an outpatient and just go for therapy every day. So that becomes their new norm in terms of working. They are working to get their body functions back to their pre-existing, pre-morbid self. And family dynamics. So as a rehab professional, one of the things that we must pay attention to is not only the individual, but also who is that individual being supported by? Who is the support system for this person? That is very important to know and understand, and be able to develop some rapport with the support system, because what they are going to be experiencing and going through, even after, say, they stop therapy, they're going to continue to need additional support for many years to come. So understanding the family dynamics, oftentimes what we see is a rise in divorce rate because of a traumatic brain injury. Some of the things I will dive into in a little bit is the challenges of some of the structural personality changes that occur. Another thing that we often don't think about is, if a person acquires a traumatic brain injury, their presentation might seem fully functional. We have to keep in mind the cognitive pieces as well. Some people do experience a traumatic brain injury that is major, but recover physically, but not cognitively. So what that looks like from a rehab standpoint is, if we can refer them to a neuropsychologist or a psychologist or someone to provide additional evaluations, we would want to look at a neuropsychological evaluations to provide specific information on how their brain is functioning with a battery of tests that are provided. Now, this provides us so much information on their abilities and limitations. Some of the other things that we can do as well is get them set up for a vocational evaluation. If they appear fully able, if they don't experience any limitations physically, we do want to see what that looks like from a coordination standpoint, from a speed, processing. We want to pay attention to those things, because just because physically they might look okay doesn't mean that's going to represent itself in an employment setting. So we have to be mindful of that and what that looks like and what kind of services we set up for them, because we want them to succeed. So paying attention to those things as well is very important. And the information we get back from a neuropsychologist or a vocational evaluator will provide us the insight into making an informed decision with the client, so that we have a better picture of what this looks like long term, of what the recommendations are from each party. And those are only a few things that we can do to get more information. There are definitely many more, but those two come to mind because those happened most frequently in my setting. And now, population-wise, what we do want to consider, domestic violence. So survivors of domestic violence, there was a study once done that found that 67% of women survivors of domestic violence had symptoms associated with a brain injury. We would not necessarily look at that offhand. Is this something we'd have to be told and informed about? So it's a population to think about in terms of what the actual person, the survivor, might be experiencing in terms of effects from a brain injury. We also want to look at the military population, people in prisons. There was another study done that I did not pull the percentage off of that showed a high percentage of people having experienced a brain injury at some point in their life. So we do want to pay attention to these things because substance misuse occurs with people with brain injuries. There's a high level of addiction that occurs after a brain injury. So when we think about care, continuum of care, it is very important to understand kind of the path that someone will walk through having acquired a traumatic brain injury. Let's put it at a major traumatic brain injury so I can give a good run through. Where they start is once they enter the hospital, they're in acute care rehab. They're going to receive rehabilitative services in the hospital and will be there for a short period of time. It's not, depending on the insurance, depending on how the hospitals are set up, they don't always get to decide on how long they want to keep them. There's some restrictions there. Then from that phase, they move into a post-acute rehab setting, treatment setting. And what that provides is traditionally speech-language pathology, occupational therapy, case management, physical therapy, nursing, behavioral analysts. Most locations I have found do not provide counseling, but I was a part of an organization that did provide counseling as a service in the recovery process, which was really neat and very vital to the work that we do as rehab professionals. And then also integrating family into that post-acute setting of treatment. That's very focused on recovery. They're there for hours a day, every day. Again, the restrictions here are either anticipated outcomes in terms of a date or insurance. Unfortunately, we don't have control over how long someone is allowed to stay. And for private rehab, that really utilize insurance only, private insurance companies. There are barriers to that as well. That means that there are people that do not have a private insurance that have a traumatic brain injury might not be able to receive the same level of care, which is another barrier to rehabilitation for them. And then we have, after that, depending on the severity of where they are in their recovery after post-acute rehab, they might move into a long-term home and community, which could be a skilled nursing facility, a long-term residential treatment center, or an outpatient and day treatment center. For where if we are looking at stepping into a more vocational role, those are the ones that we'd want to target, are the ones that are in an outpatient and day treatment service. We'd want to get them started before they terminate completely, so that due to the time that they might be in therapy, we still want to be able to have as much support as possible. So if they're in that setting, we have an opportunity to fill in the areas that they might be missing in terms of employment and their quality of life. Yes, school and vocational services will be in this setting as well, which we want to refer to if we are not providing strictly vocational services. If we are providing rehabilitation counseling services, if it's more individual counseling, that should still continue. What happens oftentimes is when they leave a treatment center, that is all that they are going to get. And then they are supposed to reintegrate back into society. So how do we as rehab professionals come in and still provide that support through their journey? Just something to keep in mind in terms of annual estimated cost for people with traumatic brain injuries for treatment. It's $7. There was a study done that looked at, kind of gathered all the data for the cost, and that was at what they pulled was $76.5 billion a year for treatment for traumatic brain injury. That's a lot of money for the services that they need. Oftentimes, as we have seen with Medicaid and Medicare, where there are cuts, they are impacted by the amount of treatment they're able to receive and the amount of providers that will provide that service to them. Some of the options that those individuals have are home and community-based services. So oftentimes they will have therapy in the home, but that is not frequent and as intensive as if they were going to be in a post-acute rehab setting. So one of the historical things we want to look at in terms of traumatic brain injuries is the Traumatic Brain Injury Act of 1996, which expanded efforts to identify methods of preventing brain injuries, which also expanded biomedical research efforts to minimize the severity of dysfunction as a result of an injury, and to improve the delivery of and enhance quality of life. So what we attempt to look at is a person-centered care approach. And that looks at three things. The person served can be trusted to lead their own lives. Secondly, it provides attitude and therapeutic relationships that are major factors in outcomes. That's what they view as one level of importance, and intervention methods that are aimed at adapting the function of the individual for meaningful participation. When we talk about meaningful participation, that is living with the least restricted life as possible. So that might include assistive technology. One of the things that you will find with people with traumatic brain injuries is the use of assistive technology. There's it's called AFO, or ankle orthotic and foot brace, and that is meant to help people with functional limitations in their limbs when walking. Oftentimes people with brain injuries use canes, use walkers, use wheelchairs, electric or manual. So we want to be aware of what types of devices people use so that we can best either provide them that piece of equipment or help them acquire that through an external source to help them live less restrictively. Those are going to be some of the things that we have to do as a rehab professional, and kind of break those things down in terms of what does this individual need to be successful? What does this individual need to move forward? If I'm looking at a private practice type setting where you're providing individual counseling to people with disabilities, you can still be that person to connect them to a resource that can meet their needs. Oftentimes that is what I've experienced in private practice. Working with people with disabilities is having to have a list of resources ready, or contacting them myself and getting them connected to fill in those gaps that they might not be receiving. It might not always be an employment need. It might be just a quality of life need, independent living type of aspect. So my recommendation is to be familiar with your local resources, make those contacts, get involved with and learn what they provide to people with disabilities. It will be tremendously helpful. Okay, so moving down, I want to touch on challenges of self-awareness. So self-awareness sometimes is largely impacted by someone with a traumatic brain injury. Specifically, frontal lobe injuries impact self-awareness. So the self-awareness really takes a toll on the individual's ability to adjust to their disability, the individual's ability to accept their disability, the individual's ability to integrate into the community and within the family. Someone that has and does not have self-awareness really struggles with understanding, why can't I drive? Why can't I go to work? Why can't I do X, Y, and Z? Although the functional wise, there might be a reason. You might see it, they might not see it. It is really difficult for them. So counseling individuals with um, limited self-awareness is really challenging, because theoretically, whatever your theoretical orientation tells you, when working with difficult clients, we want to be they don't always talk about the disability component of limited self-awareness. So what does that look like in practice? It is very important to understand that these individuals might need additional time, more than those that have self-awareness, to move forward through their recovery, because that's going to be a big barrier for them. Um, and one of the things as rehab professionals that's so great is that we work well with others in terms of services. So interdisciplinary teams such as occupational therapy, speech therapy, physical therapy, case management, vocational rehab, neurologists, behavioral analysts, nurses, families, licensed chemical dependency counselors. We can work well with all of them when working with people with brain injuries. It is very important to be integrated into their care and understand what pieces they are receiving out in the community that help fill in those gaps that they might be experiencing. From a multicultural standpoint, it is important to understand what that disability means to the individual if they do have self-awareness. One of the aspects of adjustment is grief and loss, for a family as well. So in counseling, we want to look at the family member as well. Oftentimes, what some people do, if they're trained to work with couples, is provide couples counseling for an individual that has acquired a traumatic brain injury, and for the spouse that is acquiring a lot of additional roles that they may not have had before. That is also something to be mindful of. So if families oftentimes do need that extra support, because they might not have someone to talk to about these things that are difficult and hard. So as a clinician, we are able to provide that assistance for them to adjust to their disability, for them to understand what this means for their life, that concept of the new normal. That it helps. We get to help them through that process. We get to help the families with providing education and resources, and helping them understand what this means for employment, what this means for quality of life, what this means for community integration, and so forth. We really get to meet them at that level to provide a side of a more holistic side that they may not receive. One of the things that I also want everyone to be mindful of is what messages they receive from the hospital, from the treatment facility, and afterwards are things I can't do. I can't do this, I can't do this, I can't do this. They're constantly being told what they can't do for a reason, in terms of their medical model, because they want to fix it. For us as rehab professionals, we're not going to look at it from a medical model standpoint. So the idea that they can do all these things is a piece of all that they can do. So we're going to focus on their strengths. And that's really something very important to look at, is what strengths does this individual bring, and how can I help maximize them and let them see it for themselves to move them forward. That will be a part of the adjustment process that they might experience. And we're almost out of time. I want to just touch on child and adolescent, some implications for them, some things to be aware of. Things that occur at a young age in terms of a brain injury might not be so evident in the moment. It might take some time to develop. So what you might experience is, in terms of getting that background information, is understanding what happened before in their life, to really understand kind of where they are now and what they're experiencing. People with brain injuries often have a change with behavior, personality shifts, aggressive tendencies, addiction. There are many things that come with a brain injury that they might experience. So oftentimes when families are experiencing grief and loss, they are experiencing the loss of the individual that they knew. Excuse me. And also having to get to know someone new, someone that they don't know, because some certain aspects, depending on the regions of the brain that were affected, can alter their personality and how their characteristics. I want to be mindful with time. I think that's all the time I have for today. I hope I provided some good information, and I hope you all enjoyed it. I will be back to discuss neurodevelopmental disorders, but I did want to touch on this, and I hope I was able to provide some useful resources and knowledge on what people with traumatic brain injuries might experience. I appreciate it so much. Bye, guys.